Okay, rheumatoid arthritis. The lupus patient had joint problems. Guess what? These guys do too, right? This is like one of my world's most boring PowerPoints, but I guess it's okay. We'll get through it. That video is for you to watch on your own time. It talks about rheumatoid arthritis and what it does and all that stuff. And so it's interesting. YouTube videos sometimes help you sink something in. It's just a different way of learning it and looking at it. If you want to kill some time in class, you could look at it, I guess. But got to 5. All right, rheumatoid arthritis. 2.1 million people in America have RA. 1 out of 100. So that's a huge portion of our population. When you've been in hospitals in acute care med-surg settings last semester, right? Patients come in for, I have surgery needs, or I have an infection, pneumonia, whatever. And then they always have underlying conditions. Type 2 diabetes, arthritis, hypertension, CHF, right? Always have it. But RA is one of those that you see all the time. It's those comorbidities. So one of the problems we have is how does this disease affect their care when they're under our care for something else? Like I'm here for surgery, but I have RA. RA interestingly starts in young adults, right? 20 to 40. There are children, adolescents, and infant. There's infant rheumatoid arthritis. There's child rheumatoid arthritis. So it can affect any age group. It's most prominent in the young adults, right? That's when it's starting. It affects you all your life once you got it, but it comes on in young adulthood. It is not a respecter of persons, infants, children, all races. Women 3 times more likely than men. Okay? Guys, we're getting to you. Eventually you're going to die too. But, but in this unit, it's lots of women more likely. Okay? If we don't treat the symptoms when they arise, it'll turn into joint destruction. It might still progress with joint destruction, but our treatment of their symptoms helps to reduce the joint destruction, and that's what it's about, is keeping them moving and active and their ADLs up as long as possible, right? All right, so the synovial fluid, we have synovial joints, right? Our fingers, our toes, right? The synovial fluid eases movement, right? It's a cushion in there. And it allows, at the end of your joints, you'll have this cartilaginous end, and you don't want it rubbing against each other. The fluid helps to lubricate that, right? All right. And so the articular cartilage covers the end of the bone. It's supposed to be smooth with the synovial fluid in the middle, okay? And the synovial membrane surrounds the joint sac. It secretes fluid into the space. It's a shock absorber, a lubricant, everything. Okay. RA ends up causing synoviitis, inflammation in that synovial area of the joint. Okay. All right. We don't yet know what causes RA. Is that a surprise? All these things like that. Well, we know kind of what pathologically happens, but we don't know why it starts. So we're 99% sure it's autoimmune. They have a genetic marker, HLA shared epitope. Just so you know, there's a genetic marker. Well, people have genetic testing. If you have that genetic marker in your DNA, are you going to get RA? No, it's that principle of all the conditions are right for it, but if you get that trigger, then you can develop RA, whatever that trigger is. We think infectious agents might have something to do with that. We talked about Epstein-Barr with MS. That's one of the common ones. Herpes is another common one that we considered. All right, other considerations. Estrogen and progesterone hormones in your body might be a reason people get this. It might be hormone sensitive, because 70% of RA people are women. All right, obesity. We know people who are overweight are more likely to have RA. Obesity is an indicator in osteoarthritis too, right? Obesity puts extra stress on your joints and causes your joints to work more. And so if they're going to fail, that's one of the reasons that it can fail more. Yes?
Would hormonal birth control exacerbate it, or?
Yes. Some hormonal birth controls could. Yeah, there's varying types. If they're going to take hormonal birth control, yeah. So stress exacerbates their symptoms, and smoking and pollution are indicated. Air pollution mostly. I mean, like, we're not talking about somebody threw their trash out on the side of the road. We're talking about air pollution. So in certain areas where pollutants are really high, people with RA have more symptoms. They exacerbate more. So there's a good reason to live in Texas. We have lower pollution rates than several other places, but don't go to Houston. Okay. That's kind of good advice in general, right? Don't go to Houston. I got a daughter who lives there. I shouldn't be saying that. The Houston Chamber of Commerce is going to get me. All right. So what happens? Inflammation is the problem. With all autoimmune diseases, inflammation is the problem. That's why I'm teaching it in immunity. So the pannus, they develop a pannus. Okay? It's an extra layer of stuff that forms in there, right? And it's not supposed to be there. It's like scar tissue and obstructive stuff, right? And then your T cells, you know those T cells, they say, ooh, antigen, but this time they're thinking, you're the antigen, it's you, your joint, your body is what I'm attacking, right? So it makes your own collagen cells, which are obviously in collagenous tissue. We just talked about pannus and synovial membrane and cartilage there. It attacks that and it destroys it, so it gets pitted and damaged. Okay? So we think that bacteria or virus forms an abnormal gamma globulin group. RA patients have antibodies against the abnormal gamma globulin. Rheumatoid factor is what we call that. The autoantibodies then attack their own body. They form an antigen-antibody complex. They activate the complement system, which says inflame, get irritated, everything swell up, everything get painful, all your joints, right? That's what it's attacking. Our neutrophils are to the rescue, right? It was like, ooh, here's an antigen-antibody complex. We're to the rescue. And the phagocytic process ends up damaging, because it's attacking the cartilage and the synovial space, right? So those neutrophils are like, well, let's go attack that. It doesn't belong here, so it damages that synovial area. Okay? And then the tissue macrophages come in. They secrete more pro-inflammatory substances, which promote the inflammatory response even more. So from the perspective of the patho, if we can stop inflammation early in the cycle, we're going to prevent joint damage, right? Because it's the inflammatory process that's destroying joint. So here's a picture of an RA joint, and it points to the eroded cartilage and the pannus formation, increased joint fluid from here and here. The synovium is inflamed, reddened, and swollen, right? It's irritated. All right, so I think here this was a normal. Yeah, we have normal, and then it shows the pathologic process that moves on. And you don't have to memorize every detail of this. I put some pictures of hands in here. Hands, ankles, most commonly affected by RA, and then the larger joints. But the smaller joints are affected earliest. That's like usually where the symptoms are going to originate. What you're seeing in this picture is something called ulnar drift. Ulnar drift. Let's say ulnar. What does that mean? It means wrist. Wrist. And normally I'm like this, right? And everything's lined up. The RA patient, everything is shifted, right? So you can see how here's her wrist. You see how it goes this way, and then her fingers go off this way. That's called ulnar drift. And it can be very disabling, trying to open a door or unscrew a jar lid or something like that with your hands deformed like that. Okay, so the classic symptoms of RA, this is what brings people to the doctor. My joints hurt. They're red. They're warm to touch. They're swollen. They might be shiny because things get swollen enough the skin smooths out and it gets a shiny glow. And they can't move it as well. It hurts to move it and they have limited range of motion. If you palpate those joints, it might feel boggy, spongy, dense with fluid. And then what the doctor will do is aspirate, whichever way you want to do. Take a needle, stick it in there, pull out some fluid, and he's going to now analyze that fluid to see what's going on with it. All right. The onset, there's an acute onset. RA always starts with I've never had this before, and now, whoa, what's going on in my joints? I have this acute initial onset. It will develop it over weeks to months, up to 6 months, a half a year. But over that course of time, the joints are getting thicker and swollen and reddened and sore and everything else. The interesting thing about RA, it's different than OA. OA can affect, osteoarthritis can affect just one joint. RA is bilateral. So if you have it in one hand, you're going to have it in the other. Okay, it's progressive too. And it's systemic. We're going to learn there's lots of systemic effects of RA that are outside the joint. So one of the things that they often complain about when they come in, first thing when they wake up, they're so stiff and sore. It takes them up to an hour to get up and moving. Make sense? Everything hurts. Okay. Again, begins in the small joints, hands, wrists, and feet, affected first, but bilateral. And one of the things they'll start having is a weakened grip. They can't hold things. They try and grab something and hang on to it. And the longer you hang on to something, the more it's going to hurt and the weaker you're going to be. And so you drop things more often if you're trying to hang on to them. And their hands will become more painful, and the pain causes them to favor it and not use it as fully. And then it can become non-functioning as the scar tissue develops and joint movement is decreased. All right, so what do we see? During a flare, during an acute exacerbation of RA, hot, swollen, painful joints, from our point of view, one of the most important things we can do at that point is immobilize that joint. Immobilization is a touchy subject with RAs. We immobilize during acute exacerbation. We exercise every other time. Because our big goal is keep them moving, don't lose joint function. That's our big goal that's overarching in RA. Keep them moving, don't lose joint function. If I immobilize something for very long, it's going to lose its function, right? We're going to have atrophy, and we'll have the joint contractures that occur, and everything becomes immobile. So, but I'm acutely painful, sore, and I'm flaring. I need to not use those joints. I need to let them rest for just a little bit, right, during that acute flare. We can use heat on non-inflamed joints, like in the morning when they wake up, they're a little stiff. Heat's really helpful. But if they have an acute inflammatory process, we don't want to put a warm soak, a hot bath, anything like that on there. What's heat going to do to inflammation? It's going to bring more products of inflammation in and make the inflammation worse. So we use cold on acute inflammation, warmth for the day in, day out stuff. Right? Cold constricts, cool, not so much an ice pack, but cool. Okay, so over time, begin the small hands effect, you're going to get progressive joint destruction, and things are going to slip, and ultimately that pannus is going to eliminate your joint space. But it is systemic. It is systemic. So there's areas that are affected all over the body, and we have to teach RA patients that if they have these things, they're entering a flare, and they need to talk to somebody and treat the flare, right? Could be talk to their provider, or if they have treatment already, like that they know what they do to their flares, initiate that. So they may not be able to sleep. It's an acute inflammatory process that affects the whole body, so a fever is likely to occur, right? Depression and mood changes, why would that occur?
Because they're in pain?
Chronic, that pain comes and goes, and it's all the time, and their mobility is being affected. It affects your overall mood. We're going to do that this afternoon. Dry eyes and mouth. They get Sjogren's syndrome, which gives you all kinds of dryness issues. Tears, saliva. We'll talk about that one in a minute. I got a couple slides on it. Weight loss. I know, that's actually kind of a good thing and you want it, but I don't want to get RA to get it, right? So they lose their appetite with anorexia, and the inflammatory process causes increased use of metabolic products, and they sometimes can't eat well. Grabbing a fork, grabbing a spoon, opening jars, cooking. Takes work and hand work. All of those things do. And sometimes they just skip it. It's easier not to eat. It is. Then if it's going to hurt every time you move, I think I'll just skip that right now. So they're having weight loss, joint pain, swelling, and stiffness that's symmetrical, pain that starts in the fingers, then spreads, the joints look red and discolored, pain in the big toe. Now there's another osteoarthritic metabolic problem that gives you pain in your big toe. What is that? Gout. Gout causes pain in your big toe from uric acid crystals. And so we are aware RA patients are probably higher at risk for gout, and so we have to treat that uric acid if it becomes a problem. But if it's not, RA can cause pain in your big toe too. All right, joints are warm, numbness and tingling in your hands. That can mean you're getting neurologic involvement. All right, it's insidious, it's slow, it hides, it comes up on you and you're not even aware of it. So I've had pain or stiffness for longer than 6 weeks. I've met one of my diagnostic criteria. If I had joint pain for a couple of days and it went away, that doesn't count, right? I can go to the doctor and say, my joints hurt 3 weeks ago for 2 or 3 days. He's going to go, not RA. Right? Morning stiffness longer than 30 minutes. I thought that was just age. Small joints before large joints, bilateral. They will get subcutaneous nodules, Heberdine's nodes, over their joints that you can actually palpate. Well, I think I've got something on that here in a minute. And then, along with that, this inflammatory process, anorexia, fatigue, and a low-grade fever. Because that kind of goes along with inflammation in general, right? Everybody's inflamed, tired, and a low-grade fever, right? And so, in the joints, it's a condition of exacerbations and remissions like every other inflammatory process we've talked about. Is this still working or not? It is still working. Now it is. All right. I can't even tell that it's working. I guess that's a good thing. All right. So then I remember I said it's systemic. So the joints is cardinal. That's cardinal symptoms, diagnostic, early diagnosis. Your joints are your first problem. But as you have RA, the rest of the body's going to be affected. So Sjogren's syndrome, dry eyes, painful, gritty eyes that are photosensitive. The light bothers them, right? Mouth is really dry, and because of dry mouth, it causes gum irritation and an increased likelihood of developing caries. What are caries? Good oral hygiene. They get their rheumatoid nodules under their joints, over the bony areas. You can feel nodules. In the lungs, they'll get inflammation in the lungs, which causes scarring in the lungs, which ultimately is going to cause increased respiratory difficulty. They'll have decreased flexibility of their lungs, scarring in their lungs, shortness of breath, fibrotic, pulmonary fibrosis. Have you heard of that? Then blood vessels they're going to get vasculitis, inflammation of blood vessels. Now, what's they going to put them at risk for? Inflammation in your blood vessels puts you at risk for what?
Strokes, heart attacks.
Because of clots. Anywhere there's inflammation in your blood vessels, the platelets are going to go, ooh, I need to stick. And they're going to start sticking together, clumping, releasing the products of clotting, and develop microemboli. So we have to watch for that. Feltes syndrome. Sjogren's syndrome is the fluid, the dry stuff. The Feltes causes leukopenia, anemia, splenomegaly. I don't have anemia up there, but it causes that too. It's under it, but not indented. So leukopenia, decreased white cells. So not only are they inflamed, now they're immune suppressed. They're susceptible to every little disease that comes along. Splenomegaly, what is that? An enlarged spleen, wrong side, spleen, liver spleen. So your spleen is behind your stomach, kind of off to the side over here. It's a reservoir for blood. We use it in the case of emergency. We need a quick dump of a pint of blood. The spleen will help out. Spleen is also a large lymphatic filter, right? It filters out junk. And in the process of this inflammatory process, it'll filter out all those antigen-antibody complexes. It works overtime trying to, it doesn't get them all, but it tries to get them, and it gets enlarged. Spleens can rupture, and that can be very dangerous with hemorrhage, right? Anemia, low hemoglobin, low hematocrit. They're fatigued from the inflammation, but if you don't have red cells, you're not going to carry oxygen. Hemoglobin measures what?
Oxygen carrying capacity.
Because it measures the iron on your blood cells, so oxygen carrying capacity. Hematocrit measures what?
The proportion of your blood cells.
Red blood cells to plasma. How many red cells are in this plasma? So it's a percent, and the hemoglobin's a number, and it's different for men and women, right? Men have slightly higher hemoglobins than women do. So hematocrit is number of cells in plasma, in the total blood fluid. Hemoglobin is the amount of iron carrying capacity, heme groups you have on your red cells. Both can affect your oxygen carrying capacity, and oxygen is needed to run, jump, dance, eat, swim. So it's going to cause fatigue, right? Can't make ATP. It's systemically inflammatory, so the pericardial sac, this happened with RA1. It's happened with lupus as well. The pericarditis, the inflammatory sac around the heart, became inflamed. And when that sac becomes inflamed, it's going to do what? Inflammation brings swelling, right? Swelling means fluid is moving into the area, right? That's what that means. If you have a sac around your heart and it fills with fluid, inside that sac is supposed to be a pumping heart, right? So if your heart is pumping, but fluid's building up around it, is it harder for it to pump against the fluid? So you might have pulse deficits, you might have pulse pressure changes, you might have weakness, decreased cardiac output. They could all come from that pericarditis. It can cause inflammation on the valves, specifically the tricuspid and the bicuspid valve, mitral valve, and right? You know our valves of the heart, right? Okay. So the inflammatory valve process, if that scars, they might end up being a candidate for a valve replacement. Okay. Now it's going to be the mechanical one, not human tissue, because they're not a good candidate because of rejection. All right, peripheral edema and neuropathy. So they're swelling, their legs swell, their calves swell. Neuropathy means abnormal neurologic, whatever nerves do. Transmission, thank you. Whatever it is that nerves do, I don't know. So they'll get pain, weakness, shooting pains, numbness can also occur. Raynaud's phenomenon, we talked about that in lupus as well. That's the one where what happens to your hands? They get cold, they turn blue. I can't tell you, I like to tell stories because it keeps my lectures just a little more interesting. Many moons ago in a galaxy far away, when I was a young nursing instructor, I had a student sitting right where Miranda's sitting. And every time she picked up her Diet Coke in my class and drank it, her fingers turned blue. So we got to Raynaud's phenomenon, and she's like, this happens to me all the time. And we actually talked to her about it. We're like, we're noticing, nurses always assess wherever we are, right? We're like, you got high cholesterol. You got it. But everywhere, her fingers were turning blue every time she picked up her Coke in class. So we ended up talking to her about it. She actually had Raynaud's phenomenon. She went and got it checked. Raynaud's phenomena is present in a lot of autoimmune diseases, right? It's also present in a lot of cancers. And she actually had lymphoma. And sitting in the front row of class with her fingers turning blue is how she got early diagnosis for her cancer. Isn't that cool? So watch out for your symptoms, catch them early, and report them. So I'm not saying Miranda has Raynaud's phenomenon. She just has to be sitting about where Christy used to sit. Okay. So report your Raynaud's to somebody. You could have RA, you could have cancer, you could have lupus, you could have a gazillion other things. All right, so how do we diagnose this? If it's like 6 months of insidious and joint stuff coming up, patients aren't going, well, I think I feel a little edema in my joints today, and tomorrow they're calling back going, oh, well, things are a little redder today. We're going to go, stop calling, right? So it's insidious, it's slow. So they come in for diagnosis, we get this H&P, and we start listening to things. Getting out of bed in the morning. Takes me an hour to get going. My joints always hurt in the morning. When I'm tired or when this happens, it's worse. Not hungry, I've lost some weight. And so they're checking off. Oh, it's beginning to sound like it, right? So we look at the swelling. Then we go draw some blood. And in your blood, we're looking for rheumatoid factor. Remember, there was a tag that we can find for this disease, rheumatoid factor. We're also going to look for ACPA, anti-citrullinated protein antibody. Big fancy name. It's just an antibody in their blood, and if they have it, we know that it's likely they have RA. I don't know what LA is, but they have RA. CRP, ESR, inflammatory markers, right? You guys know those? Cold. They'll be so easy to see on the test. Possibly an elevated ANA, anti-nuclear antibody. This is not new content. We talked about it in lupus. Many autoimmune diseases are positive for ANA. Lupus is a big one. RA also may present with ANA. They're going to have a rheumatoid factor. They may or may not have an elevated ANA. We'll aspirate to that synovial aspiration. We're going to look for fibrin in the synovial fluid. We'll do some x-rays. We're going to see joint destruction and damage, especially in later stages. We know it has to be over 2 joints. It's bilateral and has to last longer than 6 weeks for us to actually label it RA. So our blood tests we do, we know what ESR is. It increases when you're inflammatory and the more severe the disease gets. What this does, the red blood cells settle out in blood. If you just let blood sit, the red cells are going to sink to the bottom, plasma is going to rise up. And they have an increased rate of inflammation. And so you can't make it only on an elevated ESR because ESR is going to go up with every inflammatory condition, right? But rheumatoid arthritis is systemic effect. Remember, red cells are one of the areas that were significantly affected with RA, right? The anemia piece. So if red cells are affected by this inflammatory process, it's very likely this is going to be an issue with them. Then C-reactive protein and ANA. Hemoglobin hematocrit, we're going to look for anemia. X-rays in early RA, it's not going to show us anything because in early RA, when it's first starting, there's not a lot of destruction. There's just inflammation. But as it progresses through the 4 stages, when they get to late RA, you're going to see massive joint destruction on X-rays. So we'll use X-rays to monitor the progress of the disease, see what stage they're in. DEXA scans. What else do we use a DEXA scan for? Body
Composition.
Kind of. We also use them for osteoporosis. This is the dual energy absorptiometry. And that's the one that if they think you have osteoporosis, they put you on the table and they look at your hip, they look at your shin, they look at your forearm, look at your spine to see if you got bone density from calcium loss, right? And so they actually, RA patients will lose bone density on the bones distal and proximal around the joint that's affected by the RA. So DEXA scan can demonstrate bone loss and bone destruction. All right. Is it RA? Remember, lupus you had to meet certain criteria. RA does too. 4 out of 7 criteria have to be met. Morning stiffness, 3 or more joints. Now we said we're not even going to talk about it unless it's 2 or more. We're not going to call it RA until at least 3. Arthritis in the hands, symmetric, bilateral, equal on your sides. RA nodules. I'm not trying to read my slides to you, but I know I'm being boring today. I'm sorry. RA nodules, elevated RF, and X-ray changes. And if they have at least 4, then we can say probably RA. We think that's what this is. We're going to treat RA. So then we got to give some meds. We're going to change your life. So range of motion exercises, Rome, which is a great city, but that's not what it is. It's actually range of motion keeps you strong, helps with endurance, keeps their joints moving, allows them not to have loss of function in their joints. Heat when?
When it's not inflamed.
When it's not inflamed. Cold when it's inflamed. Heat when it's not. Rest your joints during a flare. Rest your joints during exacerbations. We'll protect their joints by sometimes even splinting them if we have to, because some joints are just really hard not to use. Teach them how to do their self-care even with joint limitations. So we have to help them with adaptive devices. There's all kinds of toothbrushes, forks, spoons, everything. Have a lot of adaptive devices to help you with your limited movement. And then our drug therapy is aimed at stopping bone loss, decreasing inflammation, and keeping them moving as long as possible. Of course, we want to limit side effects. So our number 1 nursing problem with RA is pain. That's going to be the limiting factor for most of our patients. The joint pain causing them to not be able to do stuff. Plus, if they have pain, they're having inflammation, which means joints are being destroyed. So we treat the pain by treating inflammation and pain. So what over-the-counter pain med treats inflammation and pain? An NSAID, right, okay. Yeah, so it makes sense, right? Why that, not Tylenol? All right. We also want to, our number 2 thing is their physical mobility. Remember, I kept talking about how important it is to maintain joint function. Keep them moving, keep them moving. Fatigue, overarching problem also, they're not being able to sleep. So all the other things are going to trickle on down. All right, this right here, what that patient has going on, that joint is contractured in that position. It will always be like that with the RA. It's now happened. It's a late happens as the joint disease progresses. That's called Boutonniere's distortion or Boutonniere's deformity. Boutonniere's. So like a boutonniere's the thing that you pin on your collar if you're a guy going to a wedding or a prom or something, right? And it's called that because when you pin the little thing on, that's the move you have to make with your hand. So I don't know why they came up with that name, but somebody did. Either that or Dr. Boutonniere. Okay. So inflammation and autoimmune response, we talked about that, relieving pain. Oh, it's just the same slide. It just forwarded it. Okay, this hand. Okay, Boutonniere's was this joint, right? Stuck like this. Here, you see the arch in this finger here, and then this joint is contractured and flexed. This is swan neck deformity. You think of a swan? Swan neck deformity. So, ulnar shift, swan neck deformity, and Boutonniere's deformity, the three big deformities of the hands in RA that we look for.
Can I say this for you again?
Yes, of course I can. Swan neck deformity, that's this one. Boutonniere's deformity, this one. And ulnar drift, this one. Ulnar, everything kind of shifts to the side. Make sense? But think about it. If you're wanting to hold a book or a notebook or a pen or, how hard with these deformities your finger, it may not happen on one finger, it can happen on all five. Okay, there's ulnar drift again. See, I'm big on these deformities. I think if we're assessing patients, we need to know what they are. All right, so pain, again, the biggest reason people seek help. So what do? Massage is wonderful. Keeping them moving during times of unflaring. Rest, supportive pillows and splints when they're acutely flaring. Relaxation exercises, diversional. Getting your mind off your pain goes a long way in handling your pain. So diversional activities, we talked about that. Guided imagery, music. You guys are good with pain and all the alternative methods of pain response. You've done that. Sometimes it's hard for me to know what you've done and what you haven't done because semester 2's changed instructors like 3 or 4 times in the last 2 years, and I don't even know what you like. If you get, I think hopefully now we're good. Okay. But semester 3's changed instructors 3 or 4 times. I'm new to semester 3. Analgesic, antiinflammatory, anti-rheumatic medications, obviously. TENS. What's a TENS unit? Yeah. Electro-neurologic stimulation or something like that. And so what it does is you put it not directly on the area of pain, but a little bit above it, and it stimulates with little electrical jolts. And what it does, it's based on the gate theory of pain control, that if you can send a stronger or different impulse, it'll shut down the pain on one side because it's paying so much attention to the other. And the TENS doesn't hurt, it's just keeping your brain busy going, oh yeah, something's buzzing and moving over there, and it's supposed to help distract you from the pain. Hopefully. All right. We talked about heat and cold. Heat relaxes, never with inflammation. Getting them up in the shower first thing in the morning for that morning stiffness. The nice warm hot shower is going to help loosen them up, get them moving again. Safety. Hot and cold treatments are some of the #1 reasons patients have injury from nursing and medical care. Out of all the reasons nurses and doctors get sued, there are a few that are overarching. Things like restraints, falls, things like that, of course. But hot and cold treatments causing skin injury is one of the top 3 or 4 for reasons people get sued. So that's because we don't do what we're supposed to do if we're not being a careful and good and astute nurse, right? So if you put heat or cold on someone's skin, what do you have to do? You have to protect the skin. So you have to have a towel or something to not have direct heat or cold. You have to document what the skin looked like before you put the hot or cold pack on. And that is extremely important. And then you document that this is intact skin, no redness, no swelling, or it's red and inflamed before I put it on, so if I take it off, it's still red and inflamed. Can you see how a documentation of not documenting inflamed skin that looks horrible, and then you put your heat on, and then you take it off, and you document now that it's red and inflamed, you make it look like you were the culpable party, right? So I'm not saying you weren't if you did bad with your hot pack. I'm saying protect yourself in your charting. Be sure you document before and after treatment what the condition of the skin was, And we usually leave it on 20 minutes or less. And we have to make sure before we do the next treatment the skin is returned to normal temperature, either gotten warmer or gotten cooler, depending on what we use, right? Because hot and cold can both burn. All right. So, yes.
Can we take a break soon?
Absolutely. Why don't we take a break right now? Take yourself a 10-minute break. Sorry, I just got to going.